Assalamu alaikum wa rahmatullah. Today we are going to discuss a new lecture about esophageal disease, one of the most common upper GIT diseases nowadays, which is called gastroesophageal reflux disease. Again, this is a part of the third week of surgical rotation, which concerned upper GIT symptoms like vomiting, like regurgitation, like heartburn, like dysphagia. Most of them are related to esophageal diseases, as you might study some of them before. Okay. Starting, this is how gastroesophageal reflux. This is the gastric juice. It refluxes like that through the lower esophagus. It leads to destruction of the mucosa here. Before we start, as I used to do with you, we have to revise some basic science before we go to the pathology we are going to discuss. All of us might experience this physiological reflux episode. When you eat heavy meal, you might experience that. But when you try to understand them, you will find usually it occurs after heavy meals, but thanks God, it's infrequent. Every now and then. Why is that? Why it's infrequent? Because God create here some esophageal sphincter, lower esophageal sphincter, or sphincter-like mechanism, which I'm going to discuss in more details in the following slide. So it is infrequent because we have a sphincter here that prevents the reflux of juice from the stomach to the lower esophagus. And even if reflux occurs, and it might occur, also it is mild and short-lived. Why it's mild and short-lived? Again, because God created something to protect us again, which is clearing esophageal motility. Yani this esophagus have some peristalsis to push the refluxed gastric juice back to the stomach again. So it is short-lived, infrequent and short-lived. This is physiological reflux. All of us, most of us experience this issue. I want you to notice that sometimes it is very important for this lower esophageal sphincter to relax, to allow the passage of vomiting or to allow the passage of gases after you drink water beverage. Here is the gastroesophageal reflux. If the sphincter closed like that, no reflux. If it open, reflux will occur. As I told you, one of the important protective mechanisms is the lower esophageal sphincter. It is not anatomical sphincter, it is a sphincter-like mechanism. One of the important factors that make it act like sphincter is that the lower 4 centimeters of the esophagus is intra-abdominal. So, if the intra-abdominal pressure increase, it will compress the stomach, and at the same time, it will compress the esophagus, occlude the esophagus, and prevent the reflux. This is very important. I want you to notice, if this is lost, for example, in sliding hiatus hernia, this 4 centimeters is no longer in the abdomen, this will lead to reflux symptoms. Also, there is angle between the stomach. It does not enter directly like that. It enters with angle like this. So this acts like a valvular effect. Sorry. This valvular effect, when the stomach distends, it will occlude the lower esophagus. Also, the right crus of the diaphragm acts like a pinch coke. The mucosa has a rosette-like folds. I'm going to show you in the next slide. If you want to see, here is the right crus of the diaphragm. Here is the opening for the esophagus. You can see it acts, these fibers acts like a pinch coke. You know what's pinch coke? Here one. كماشة بالعربي. Here acts like a pinch coke action. They'll help to make the lower esophagus act as a high pressure zone. Also here the mucosa of the cardia, it is rosette-like. It is like a flower. It is not smooth. This irregularity also make it when this muscle contract, make it easy to be obstructed. Closed, I mean. Here is the physiology going to our disease and our topic, which is gastroesophageal reflux disease. What is the definition of that? The definition, it is mucosal injury. Injury of the mucosa of the lower part of the esophagus caused by abnormal reflux of gastric juice. Why I say that? I say it's abnormal because you understand many of us have normal reflux episodes, And also why I said mucosal injury, not inflammation, because we used to say it esophagitis. We consider that the refluxed acid leads to inflammation of the esophageal mucosa, but recently we found it is destruction of these cells rather than inflammation. It typically occurs in the distal 8 to centimeters of the esophagus, and it is patchy in distribution. This is the definition: mucosal injury of the lower esophagus due to abnormal reflux of gastric juice. What might be the incidence? Is it important to know that? I want to tell you, this is nowadays you consider it the most common upper GIT disease. Why is that? Because peptic ulcer incidence decrease. Why peptic ulcer incidence decrease? Because of or at least symptomatology, because of the control of H. pylori infection, one of the theories. The other theory, the presence of proton pump inhibitors decrease the acidity so much to no manifestation. It leads to healing of this ulcer. Also, this decreases the peptic ulcer. On the other hand, increased obesity increased the incidence of gastroesophageal reflux. So the number one here, decrease the peptic ulcer. Number two, increase the Gerd. So Gerd is now the most common upper GIT symptomatology. It affects 25% of general population. It affects white people rather than Asian or blacks. This is the instance. What I want to say, it's very common. You have to study it very well. The etiology, what might be the cause of this reflux? You know the protective mechanism, the lower esophageal sphincter and esophageal motility, so there is a defect in one of them. Either diminished lower esophageal sphincter pressure or incompetent lower esophageal sphincter, it's called primary reflux. Sliding hiatus hernia is the most common cause, and that's why in the second part of our lecture we're going to discuss hiatus hernia. This is the commonest cause. Obesity, as I told you in the previous slide, is also a cause of this decrease in the lower esophageal sphincter, and it will lead to gastroesophageal reflux. The second item is insufficient esophageal clearing, esophageal body dysfunction. This is the clearing mechanism I told you before. But we have another cause of this reflux, but we not included in this lecture. It's called delayed emptying of the stomach. For example, in pyloric stenosis, there is increase in intragastric pressure and there is reflux of gastric juice in the stomach. We consider it as pyloric stenosis rather than reflux disease. So we are concentrating mainly here in our lecture on primary Gerd, not secondary one. So we discussed the definition, the instance, the etiology. Now about the pathology. Here is hiatus hernia. How hiatus hernia lead to reflux? When there is a sliding of the stomach into the chest like that, the esophagus becomes intrathoracic. So when increase in intra-abdominal pressure, all will reflux it here, and this will lead to gastroesophageal reflux disease. Okay, to summarize the pathology or the pathogenesis of Gerd, we have to see this diagram. Starting with incompetent or low pressure lower esophageal sphincter leading to reflux of the juice from the stomach to the lower esophagus, this will lead to mucosal destruction. This is from the definition. First, the mucosal destruction is minimal, leading to erosion or superficial ulceration, which rapidly heal. But if it does not heal and remain and reflux episode recur, it will remain and it will lead to spasm of the longitudinal muscle, leads to shortening of the esophagus, more reflux. When reflux episode becomes frequent and the acidity of lower esophagus increase, this will lead to deep ulceration. The erosion from prolonged reflux, erosion turned into deep ulcer. Deep ulcer is a very important issue in the pathogenesis of Gerd. Deep ulcer either heal by fibrosis, and this fibrosis leads to either obstruction or narrowing or stricture or lower esophagus or shortening of the esophagus. This is one way. Healing by fibrosis leads to stricture or shortening, or healed by epithelial adhesion. First, it healed by stratified squamous epithelium like the normal lining of the esophagus. But with repeated ulceration, metaplasia occur and become lined by columnar epithelium, columnar metaplasia. To be capable to deal with the refluxed acid is called adaptation or adaptive metaplasia or columnar metaplasia, will lead to the dangerous and the famous complication of Gerd, which is Barrett's esophagus. Barrett's esophagus is columnar metaplasia of the lower esophagus. So deep ulcer either heal by fibrosis or by columnar metaplasia, These are two complications of GERD. Here is the pathogenesis of gastroesophageal reflux disease. After the pathogenesis, we have to know the clinical picture. The clinical picture, either typical clinical picture, and sure, the main symptom will be heartburn. The patient feel heartburn retrosternally. It is burning sensation. It increased by meal or lying down or bending forward, and it decreased by sitting upright and taking antacids. This is the analysis of the heartburn. Heartburn is the main symptom in case of reflux disease. Also regurgitation. Regurgitation means when you lie flat, you might feel bitter sensation, which is gastric juice in your mouth. You might feel a fluid with bitter taste in your mouth, which is the refluxed gastric juice. Regurgitation differs from vomiting. Regurgitation is effortless, while vomiting is with effort. Dysphagia early in reflux is due to spasm, but later on is due to fibrosis or stricture, when the deep ulcer healed by fibrosis. Take care, this is the typical presentation. All these symptoms are increased by food that delay gastric emptying, like fats and spicy food. Spicy food and fat increase all these symptoms. But as I told you, the patient might come to you with atypical presentation. And these are some of the famous atypical presentation for GERD. Patient might come to you with angina-like chest pain, might come to you with bronchial asthma, dry coughing due to laryngitis, and dental erosion because of the acidity of the oral cavity. Or the patient might present with symptoms of complication. I want to remind you that the clinical picture of most esophageal disease are only symptoms. We cannot examine the esophagus. So symptoms, typical, atypical, and after that, complication. What are the complications the patient might be presented with? First, peptic ulcer. This deep ulceration is peptic ulcer. Revise the definition of peptic ulcer. It's ulceration of mucosa bathed in gastric juice. The first site is the duodenum. Second is the stomach. The third is the esophagus in case of reflux esophagitis. Anemia. Anemia from bleeding from this superficial erosion or deep ulcer. Take care. Severe bleeding from GERD is very, very rare. Perforation in GERD is very, very rare, as I put here in the books. But this superficial erosion usually leads to chronic blood loss and anemia. Esophageal stricture, you remember from where? Esophageal stricture and shortening, it's due to fibrosis of the deep ulcer, and in long-standing peptic ulceration, adaptation with columnar epithelium occurs, lead to Barrett's esophagus. Take care, this is the percentage of Barrett's esophagus in GERD. Barrett's esophagus is one of the most dangerous complications of GERD. So I have to know more about this Barrett's esophagus. What's Barrett's esophagus? It's columnar metaplasia replacing the squamous lining. Why the esophagus ulcer healed by columnar? To be able to act with the refluxed acid. It becomes like the gastric mucosa, which not digested by the gastric juice, so it mimics the gastric mucosa. How it occurs? Prolonged reflux, damage of the esophageal epithelium, adaptive columnar change. What is the danger of this Barrett's esophagus? In 10% of patients, it might turn malignant, leading to adenocarcinoma. Usually, cancer esophagus is squamous cell carcinoma. But if Barrett's esophagus occurs, it will lead to adenocarcinoma. How to diagnose this Barrett's esophagus? I diagnose it with the esophagoscope. When I see a suspicious lesion, I can take biopsy. How to manage this according to the biopsy? If the columnar metaplasia is mild and moderate dysplasia, so I can follow up with the endoscope and doing anti-reflux measure. If it is severe dysplasia, we consider it carcinoma in situ and we have to resect the esophagus. Now the complication is finished. As I told you, presentation is symptom plus complication. To investigate, to make sure, to confirm the diagnosis, we have many investigations, but before we go through them, I have to remind you, the diagnostic guidelines for GERD If the patient's history is typical for uncomplicated GERD, an initial trial of empirical therapy is appropriate without further investigation. Typical GERD, without complication, start conservative treatment without investigation. But if the diagnosis is in doubt or no response to this empirical treatment, proton pump inhibitor, or if dysphagia is present, dysphagia is dangerous, so I have to do investigation. What are these investigations? Sure, I have to start with endoscope and biopsy. What is the value of endoscope in reflux esophagitis? First, you can see the reflux juice. Second, you can see the erosion. And third, you can see the stricture. You can see the Barrett esophagus like that. The Barrett esophagus appears like red patches like that. As I told you, we can take biopsy. If you need to do surgery for GERD, you have to do endoscope first, and these are the indication of endoscopy. As I told you, one of the advantage of endoscopy of GERD, it helps us to grade the degree of esophagitis. We have what we call Los Angeles classification of reflux esophagitis. You know, according to the ulceration, it's grades either A, B, C, or D. You can read them. Also, this is Los Angeles classification written in a table, easier to read. According to the size of mucosal ulceration, the presence or absence of complication. We have an old grading system for this reflux esophagitis, also by endoscope. It's called Savali mirror. So endoscope is important for Barrett's esophagus for grading before surgery. This is esophagoscopy, the first investigation for GERD. The second, this is Barrett's esophagus, as I told you, and I showed it before. The second investigation is 24 hours pH monitoring. This is the most accurate and academic method to diagnose GERD. To diagnose GERD, I have to say that there is frequent reflex episode, and this is responsible for the symptoms. How I'm going to do that? We insert a probe here to measure the pH in the lower esophagus, and I leave it for 24 hours. During this 24 hours, this patient having this with him, every time he experienced heart pain or reflex episode, he pushed certain button, and after that we have two curves, curve for the pH and the curve for the pain or the heartburn. Every time there is decrease in the pH, acidity I mean, reflux I mean, the patient experience pain, so it is diagnostic for GERD, but as you know, it's not easily applicable. Put a probe in the esophagus for 24 hours is not an easy issue. The third investigation is manometry. If you measure also the pressure here in the lower esophagus, you will find decreased pressure in the lower esophagus. This is the normal value of the lower esophagus. In GERD, there is decreased lower esophageal sphincter pressure. The fourth one is called barium meal. It is not a mistake. It is barium meal, not barium swallow. And I'm studying the esophagus because here, sorry. Here I want to diagnose that the upper part of the stomach slide and herniate through the esophageal hiatus in the diaphragm to be in the chest. So we fill the stomach with barium and make the patient in Trendelenburg position, take a photo. We'll find this finding. You will find this is part of the stomach above the diaphragm here in the chest, and here is the esophagus, and here is the gastroesophageal junction. It's no longer angle of between the esophagus and stomach, and also there is no part of the esophagus intra-abdominal anymore. Again, hiatus hernia, sliding hiatus hernia is the most common cause of reflux esophagitis, but you have to read this. Many GERD patients do not have hernia, and many of those with hernia do not have GERD. So it is not the same topic. Sliding hiatus hernia is the most common cause of GERD, but I cannot study both as the same topic. Now we finished the investigation. This is a diagram for sliding hernia, and this is a real barium meal in Trendelenburg position for sliding hiatus hernia. Again, same. The last item in GERD is the treatment. How I'm going to treat GERD, gastroesophageal reflux disease. It depends. Is it complicated or not complicated? If it is complicated, I might use conservative treatment, some instruction and some drugs we can give. If no response, I have to do surgery. If complicated GERD, I have to know what type of complication. Each complication has its own line of treatment. Uncomplicated, I have to start with medical treatment. Lifestyle modification, medical treatment is the main line of treatment of uncomplicated GERD. How I'm going to do that? I have to reduce weight, stop smoking and excess tea, coffee, alcohol, elevate the head of the bed, take small meals, frequent small meals, avoid all this which decrease the gastric emptying and increase the intragastric pressure. If the patient can do that, plus taking some drugs like H2 blocker or proton pump inhibitor or some drugs to increase the esophageal motility, to improve the esophageal motility, sure the patient will improve. But if the patient is not compliant or there is persistent symptoms, I have to go for the second line of treatment, which is surgery. So surgery is indicated when there is failure of medical treatment or in complicated case. I want to remind you, the main cause of failure of medical treatment is poor compliance of the patient. Either the drug is expensive, he cannot offer, or the side effects of the drugs appear, or he do not like to remain on drug forever. What are the surgeries we might do for reflux? The aim of surgery must return the normal physiology. We have to reduce the herniated part of the stomach. We have to prevent the esophagus to recur back to the chest. We have to make anti-reflux measure. Many operation described to do this, but I want you to know only the famous one and the most popular one, which is the Nissen fundoplication. What's this Nissen fundoplication? Nissen describe a technique that make a complete wrap of the stomach around the lower esophagus. He started like that. He reduced the esophagus again intra-abdominally. He narrowed the esophageal hiatus, and then he bring the fundus of the stomach behind the esophagus like that, and then suture it again here to the other side. So there is a complete wrap of the stomach around the lower esophagus, and that's why we call total fundoplication. Total, it means 360 degrees, all around the esophagus like that. So we have to circle the inner circle in the esophagus, the outer circle in the stomach. When the intragastric pressure increase, it will close the esophagus and prevent the reflux. The disadvantage for this issue is what we call the patient becomes overcompetent. What I mean, the normal relaxation of the lower esophageal sphincter not occur. If we take water beverage, you can eructate, you cannot leave this gas in your stomach to go up. So the patient usually suffers from gas in his stomach, what we call gas bloat syndrome. So it's very efficient, but unfortunately it's efficient till it becomes overcompetent, leading to gas bloat syndrome. The patient cannot even eructate to relieve the gas from the stomach. How I'm going to overcome this disadvantage? We have many operations. One of them is called floppy Nissen. You make it loose wrap. You make this wrap wide enough not to occlude the esophagus completely. But another modification of this Nissen is called the posterior partial. I'm not going to do complete fundoplication. I'm going to do partial fundoplication. Partial fundoplication will make a wrap of the stomach around the lower esophagus like that. We suture the fundus on the right side of the esophagus, not on this left side. So this area of the esophagus is no longer covered by this wrap. It's called partial posterior wrap or posterior partial fundoplication. It is described by Topay. Another one is called anterior fundoplication. We make this wrap anteriorly, and it's only 180, described by Dor Watson. So to summarize the surgical treatment is like that. To do Nissen fundoplication, there is advantage. The patient become overcompetent, the sphincter, and suffer from gas bloat syndrome. I can overcome this by doing floppinism, posterior partial fundoplication, anterior partial fundoplication. If the patient is complicated and come in with complications, some of them are rare nowadays, the stricture and shortening, we're going to pass on them rapidly. In peptic stricture, if dilatable, dilate. If not dilatable, I'm going to do Thales patch. Again, these issues are so advanced for undergraduate. I'm just giving the title. I'm not going to give you any more details. Also, if there is shortening, in shortening of the esophagus, I might dissect the esophagus and release it more. If it is severe cases, I'm going to do what we call cholecystroplasty. Again, it's somewhat advanced for undergraduate, giving you the names only. But here, because it's dangerous, you have to know the common and you have to exclude the dangerous. Because Barrett's esophagus is dangerous and expose the patient to adenocarcinoma, I have to know it very well. I have to know how to diagnose and how to treat. I told you how to treat. We have to do endoscope, take biopsy, moderate dysplasia, anti-reflux plus follow-up with endoscopy. Severe dysplasia, we consider it as carcinoma in situ, so the treatment is esophageal resection. This is the first and main part of our lecture, which is gastroesophageal reflux disease. We're going to study something related, which is hiatus hernia, and one type of hiatus hernia, which is sliding, is usually presented with reflux esophagitis. This is the relation between the two topics. Hiatus hernia means herniation of the stomach through the esophageal hiatus. The opening in the diaphragm for the esophagus is called the esophageal hiatus. The stomach herniates from the abdomen through this opening to the chest. We have, this is the definition, and the etiology. The etiology is the same like any other hernia, either weak wall, the wall here is diaphragm, the muscle of the diaphragm is weaker, which increase in obesity and old age, and the other is increased intra-abdominal pressure. It's like any hernia. This is the causes of any hernia. We have three types. The most common, 90% is sliding hiatus hernia. The stomach and the esophagus slide through the hiatus to be in the chest. The other one, paraesophageal. Paraesophageal means the fundus rotate beside the esophagus and the herniate into the chest. The difference between both, in the first one, the gastroesophageal sphincter junction slide and becomes in the chest. But in the other one, the gastroesophageal junction remains in the abdomen. Let us make it easier here. Here is the sliding. In the sliding, you know, the esophagus slide, the stomach slide, so the gastroesophageal junction is in the chest. But in this situation, the fundus only rotate and herniate, and the gastroesophageal junction remains in the abdomen. This is the difference in the presentation. Here the presentation is reflux disease, here in the presentation is pressure manifestation. This part of the stomach compress any other parts in the chest. If we study them separately, it's easy, very easy to study sliding hiatus hernia. Sliding hiatus hernia, the age, majority above 50, female more than males. You remember female fatty 50 fertile for gallstones, same here in hiatus hernia, sliding hiatus hernia. The investigation exactly as Gerd, barium meal endoscopy, esophageal manometry, 24 hours pH monitoring. You can revise this investigation in the first part of our lecture. Here is the barium meal finding in Trendelenburg position. The stomach slide through the hiatus into the chest. This is the finding in endoscopy. The treatment, starting with medical treatment, no improvement. I'm going to do this nascent fundoplication, the complete wrap. And to avoid the gas blood syndrome, you can do floppinism or the other modification, partial posterior or partial anterior fundoplication. The difference occurred in the second part, or the second type, sorry, of the hiatus hernia, which is called the paraesophageal hernia or rolling. Rolling, as I told you, this part rotate to herniate beside the esophagus. So there is part of the stomach here, so it will lead to pressure manifestation in the chest. It is a true hernia. It contains a peritoneal sac. In the presentation, there is no GERD, no GERD, no gastroesophageal reflux disease. But usually pressure manifestation. What are these pressure manifestations? There is postprandial chest pain, which is relieved by vomiting. Postprandial chest pain, relieved by vomiting or loud bleaching when eructate loudly. So the gas in the stomach relieved, so the pressure manifestation and chest pain decrease. Also dysphagia, dysrhythmia, dyspnea, hiccup, all these are pressure. When it compresses the esophagus, when it compresses the pericardium, when it compresses the lungs, when it compresses the diaphragm, these are pressure manifestation, not reflux symptom. All manifestations are intermittent, increased by meals and relieved by loud bleach. The complication are the complication of hernia. It might strangulate, and strangulation leads to gangrene, and the gangrene to perforation, and this perforation leads to mediastinitis, which is fatal. So it's much more dangerous rather than the other type of hernia. How to investigate? Chest X-ray, you will find the gas bubble of the stomach with gas fluid level in the chest. Barium meal in Trendelenburg position. This is the best method. You will find the stomach and the chest also, and also endoscopy. A treatment differs. If you remember the treatment of sliding hiatus hernia, the main treatment is medical, slight reflux. And if failed or there is complication, I have to do surgery. But in paraesophageal or reeling hiatus hernia, the main line of treatment is surgery, starting with surgery. Okay? The surgeon must be early. I'm afraid of complication like strangulation, gangrene, and perforation. What is the idea of this surgery? It's like any other type of hernia. I'm going to reduce the contents of the hernia. I mean reduce the stomach from the chest. Then excise the sac, then do repair. I repair the defect in the diaphragm. I narrow the hiatus. I might put a mesh to strengthen this area.